and also that I have borrowed heavily from the internet to portray the various teaching points and to make the lecture more lucid and understandable. So with this, I would go on for the topic, which is on imaging in gastric malignancy. This is the hospital where I work. Majority of our work, 50%, is related to oncology. But let me also say at the same time that we don't get to diagnose tumors as such, but only their spread, because most of the patients who come to us are already worked up elsewhere, and then we are giving them solutions or discussing the various treatment related issues. This is my team of faculty, the very learned, the very respected Dr. Sneha Bhargav as a guiding light, and my other colleagues who try to answer to our clinical colleagues' questions and queries. Why is gastric carcinoma so important? Well, it is the fifth commonest malignancy across the world, with a very low overall survival rate of less than 20%. And at the same time, it is one of the leading causes of death due to cancer, possibly the largest if you consider the entire figures across the world. The commonest type of cancer which is seen involving the stomach is the adenocarcinoma, which almost comprises 90 to 95%. The others I'll discuss subsequently. So since this is the commonest tumor, my maximum emphasis would be on this particular malignancy, how to diagnose it early and how to detect its spread, and discuss the various points which are related to tumor treatment and surgical perspective. Before we delve into that, just let us look at the various epidemiology and the risk factors. It is commoner in males. The peak presentation being the 6 to 8 decade, around 70 years, 65 to 70 years in the West, and a little earlier in the Eastern population. The East Asian is the commonest area and the Eastern Europe, followed by South and Central America. It is relatively uncommon in the Western world of US and the other Western countries. What are the other predisposing factors? Atrophic gastritis and the precancerous changes resulting from Helicobacter pylori infection. Obesity is also a predisposing factor, especially for cancers involving the gastric cardia. Use of salted preservatives, example salted fish, which is commonly used in the Eastern Asian countries, and processed and grilled meat or charcoal meat is also considered as a predisposing factor. Alcohol and smoking are known to predispose for development of cancers, and alcohol, especially if you're drinking more than 3 pegs a day, that is almost 150 to 200 ml of alcohol every day. Certain occupational hazards are people working in coal, metal, and rubber industries, and other predisposing factors are like patients suffering from pernicious anemia, people having polyps, or suffering from inherited cancer syndromes like the familial adenomatous polyposis, gastric adenoma, and proximal polyposis. So why is staging this cancer so important? As this graph shows you that the survival drastically reduces, the 5-year survival rate drastically reduces as the stage of the tumor progresses. And it's important to catch it early. However, at the same time, I would like to say catching it early has been taken away from the hands of the radiologist, and that primary diagnostic modality currently is endoscopy, endoscopic ultrasound, and EUS guided biopsy. Well, the other imaging modalities for detecting cancer spread are still with radiology, and CT scan of the abdomen, thorax, and pelvis forms the primary diagnostic modality for detecting the spread of cancer beyond the local 3 centimeters, which is best seen on endoscopic ultrasound. Laparoscopy and washing, SPECT, and MRI have roles, which I will discuss subsequently. So coming to EUS, just a slide on EUS. EUS goes over most other modalities that it can detect all the 5 layers of the stomach in vivo, and it can thus identify the depth of the invasion of the tumor accurately. Also, it is very good to detect and sample any perigastric lymph nodes which may be seen, and thus aiding to accurate staging of the disease. However, it does have its own limitations that you cannot see beyond the 3 centimeters, so it is not very good at seeing distal spread or spread to local contiguous invasion or infiltration. Further, it tends to overestimate at times because of perituberal inflammation and fibrosis. It can overestimate the extent or the depth of spread. So because of this, after the early diagnosis and local disease extent, one needs to assess the exact extent of the disease. So this involves looking at the perigastric ligament infiltration, regional and metastatic lymph nodes, direct and metastatic organ involvement, for which CT is very good, and it helps in affecting the treatment and prognosis by accurately staging the disease. However, before I move on to CT, let us just have a brief look at uh, a investigation which is almost become vestigial, that is the barium meal. Earlier, before endoscopy, barium meal used to be the standard investigation for detecting carcinoma, and there were various manipulations and techniques described for early detection of the tumor, which have now been supplanted by initially endoscopy and then EUS. So just this is a slide which helps us differentiate between benign and malignant ulcers. I'm not showing any images here between these because they might have probably would have been covered in various benign disorders of the stomach. So how does the malignant ulcer which is detected or which is seen differ from the benign? So a malignant ulcer does not protrude beyond the gastric contour, for it has there'll be a polypoidal growth or there'll be a fungating growth into which the ulcer or ulcer crater would be there. And generally, the ulcer crater tends to be irregular and shallow. It has nodular and angular ulcer mounds, which I will show in a couple of slides subsequently, and that gastric folds are nodular and do not reach up to the margin of the ulcer. So these are certain images from barium which have been which are showing cancer. This is the first A image shows a polypoidal growth which is more than 5 millimeters, and there is a small ulceration on top of it. Then the second one shows multiple polypoidal growths, nodular growths rather. The third image, the C image, shows a shallow ulcer NK with surrounding nodular areas, which are the nodular mucosal folds and nodular mound. This image shows a large ulcer with nodular mounds, and the mucosal folds which are not reaching up to the ulcer margin. However, even with the early days of endoscopy, despite it being better for detecting early tumors, however, there is one place where barium still scored, and that is in detecting infiltrative carcinomas or serous cancers of the stomach, which led to lead pipe appearance of the stomach called as Malignancies plastica. So here we see an example of a serous carcinoma, which is involving the proximal part of the body of the stomach and involving the gastroesophageal junction, which at the same time shows results in a pseudo-achalasia sign. So this is a smooth terminal end of smooth tapering of the distal end of the stomach, distal end of the esophagus, sorry, and the G junction, which would be falsely taken as achalasia cardia. However, once the study is completed and you see that there is involvement of the stomach, you know that it is the gastric cancer which is causing the appearance of this. More diffuse involvement by the serous carcinoma can lead to poor distensibility and distorted tubal pattern, which was a sign of Malignancies plastica or an infiltrating or a serous carcinoma. However, with the advent of endoscopic ultrasound and narrow view endoscopy, even this advantage of barium has been lost, and hence it has almost become a superfluous investigation. It is generally now done to look for gastric outlet obstructions at times, or post-operatively to look for any leaks. So coming to the modality of choice to detect extent beyond the local region or for adequate staging is CT scan. So for early detection on CT scan, The hydrodynamic multiphasic contrast enhanced CT is the imaging modality of choice, which not only detects early cancer, but is also suitable or appropriate for staging of regional extent, nodal involvement, and extent into the peritoneum and metastatic involvement. Well, it is said that optimum CT technique we all hear requires high spatial resolution, proper gastric distension, adequate correct timing of contrast media to detect all these changes. So how do we achieve that? How do we go about achieving that? This is done by adequate patient preparation. So patient should ideally be fasting for 6 hours. By fasting here, we take that no solids. Patient can have fluids, but no milky fluids, and absolutely no solids definitely, because they will cause false filling defects. And patient is given for water is commonly used as a negative contrast, where patient is given 1000 to 1500 ml of water. And do remember to give patient a glass full, at least 200 to 250 ml of water on the table, so that we achieve adequate gastric distension. So for certain areas, stomach, like when you're using water prone is a better situation. Then you want to look at the antrum or pyloric wall. People have also given effervescent agents to produce air to get kind of a double air distension. Some are for looking for certain areas. And here what you do is you give around 5 grams of effervescent area like Eno salt or something with around 10 to 15 ml of water. And within 15 to 20 minutes, you scan the patient within that, so that you get adequate distension. Here also certain times manipulation is required, that if you want to, which is reverse of when you give water, because water is a dependent solution and air is non-dependent. So air will tend to rise in the non-dependent area and outline non-dependent areas. So in prone imaging, you will better see the fundus vis-a-vis water when it's used. When you see antrum is better visualized. Also, lateral decubitus position is utilized to look at the pylorus or the GE junction or the cardia. You need to have thin collimation and image reconstruction is overlapping, so that you get high resolution multiplanar imaging, multiplanar volumetric imaging, so that there is no data loss. So use standard now has become non-iodinated contrast, and generally it is said that omnipaque is adequate, but visipaque or low isoosmolar contrast media is now preferred, especially though it is more expensive. It is preferred especially for elderly or extremes of age or patients with moderate renal dysfunction. Generally, we calculate the dose of contrast to 1.5 to 2 ml per kg with flow rates of 3.5 to 4 ml per second. And the phases which we covered is a triple phase standard, which is arterial phase, the portal phase. We all know this, and the delayed equilibrium phase. We know the times. Now with the bolus phase, we know that we give 5 to 10 seconds delay after the contrast is detected. For portal phase, we give a 40-second delay time roughly. And in case we do our pressure injector is not working, then after or we are not using bolus phase, then the time difference becomes 25 to 40 seconds for arterial phase after initiating contrast injection. And for portal venous phase, it becomes 60 seconds. And for delayed phase or equilibrium phase, it is 3 to 4 minutes. So this is just one example of showing air distended stomach. And this patient is in the left lateral decubitus oblique. So it's not truly left lateral decubitus, but the right side has been elevated so that air can distend the antropyloric region, and you can identify the focal subtle thickening of the mucosa. Now, when we want to describe the lesions, it is important to know the anatomy. So which part of the stomach, all the parts involved have a connotation because they have the preferred paths of spread from each area, and also surgical resection would be affected that way. Also, we need to know the arterial anatomy at the same time. Why is arterial anatomy important? I will discuss it here and probably repeat it subsequently, that when you identify these vessels, they tend to identify the ligaments. So these vessels traverse through ligaments, and these are how you identify the various perigastric ligaments, and perigastric spread of disease can then be detected earlier. Also, certain variants are important for our surgical colleagues, like the left aberrant or the replaced left hepatic artery. because if it arises from the left gastric artery, we have to ensure that the surgeon has to ensure rather that the left gastric artery is is ligated distal to the origin of the left hepatic artery. So we need to be on the lookout for this and identify this anomaly or aberrant origin of the left hepatic artery. So at the same time, I would also like, how do we divide the stomach? The cardia is the area of the stomach which is adjacent to the gastroesophageal junction. The fundus lies superior to the gastroesophageal junction from a line drawn horizontally along the point of the superior aspect of the G junction. From this imaginary line to the incisura angularis of the stomach lies, this point lies on the lesser curvature, and from this extent of the forms the body of the stomach. From the incisura distally to the pylorus forms the pyloric antrum, and from that point till the gastroduodenal junction forms the pyloric canal, which is the shortest part of the stomach, or the narrowest part too as well. So this, we need to know that this is not readily visible, the differentiation of stomach into various parts on axial anatomical images. So one needs to have a multiplanar imaging and view these on coronal as well as sagittal reformats to identify these areas and locations. Another point we need to identify is when a tumor or when a lesion is involving or reaching up to the gastroesophageal junction. So we need to differentiate from being it identified as an esophageal cancer or is it a stomach gastric cancer which is invading into the esophagus. So if a tumor lies within 2 centimeters of the G junction, so this is better identified again on endoscopy when you can identify correctly the G junction, but even then we need to be looking out for this on imaging, cross-sectional imaging, because the tumor cross-section is better visible on CT scan. So anything within 2 centimeters of the G junction, if it invades the G junction, the epicenter of the tumor lying within 2 centimeters of the G junction and invading the G junction, it automatically becomes a esophageal cancer. However, any tumor lying distal to the 2 centimeter limit, the epicenter lying distal to the 2 centimeter from G junction, and even if it invades the G junction, it continues to be called as a gastric cancer. And any tumor with the epicenter within 2 centimeters but not invading the G junction continues to be a gastric CA. Why this is important? Because the nodal as well as metastatic staging changes when we discuss or when we call it as a esophageal cancer or a gastric cancer. Before we go on to see abnormalities on CT scan, we need to know what is the normal. So how does CT look normal? What is the limits of normal on CT of stomach? So in an inadequately distended stomach, a 2 to 5 millimeter thickness is the normal range, with an upper limit of 10 millimeters, especially in the dependent portions of the stomach, that is along the greater curvature and the antral region, that up to 10 millimeters can be considered normal in a undistended stomach. But if a stomach is distended adequately, and especially air, because air leads to better distension of stomach, then 5 millimeter is considered as the upper limit of normal. Anything more than 5 millimeter is considered abnormal. So we have to differentiate it from spurious or pseudo thickening of redundant mucosa. And this, as I've explained, can be done by changing position. If we see this on the scan, so we can, if the patient is being examined on supine with fluid, so we can change, we can make him semi-prone or we can make him semi-supine, lateral decupitous, depending upon the area, which makes it non-dependent, which makes the tumor non-dependent so that it can be seen clearly from the adjacent walls. So with air, right decubitus, as I've already discussed, right decubitus for proximal stomach and G junction, left decubitus is for distal stomach and duodenum, and prone for fundus. However, this reverses when we are using water as a contrast. What are the pathways of spread? These are the perigastric. For local spread, the extension, direct extension into adjacent organs, or through the perigastric ligaments. So we need to know what these perigastric ligaments are. So commonly, these are the 5 perigastric ligaments which we need to know: the gastrohepatic ligament, which is which is also called as an extension of the lesser sac; the hepatoduodenal ligament; the gastrocolic ligament, which is an extension of the greater sac; the gastrosplenic ligament; and the splenorenal ligaments. These are important to identify and know because these are the routes of spread for stomach cancer, and the routes will also depend upon the anatomical site. So again, going to normal, what does CT do? Can CT identify all the 5 layers? No, it tends to identify 2 to 3 layers. The inner layer, which enhances the most, is best visualized and is the mucosal layer, includes the mucosa. There's a middle layer which is relatively hypoenhancing and hypoattenuating on CTs, forms the corresponds to the submucosal layer, and the peripheral layer is the layer comprising of the muscularis mucosa, the serosa, and the subserosa. This tends to be hyperattenuating but enhances a little less, relatively less than the mucosal enhancement. So these layers can be suitably made out in an adequately distended stomach, and the involvement of each of these layers would change the staging of stomach of cancer from early to delayed, and from even in advanced cancers from T2 to T3. The various types of cancer, according to Borman classification, which can be seen on CT, can be the polypoid type. Here we see the polypoidal outgrowth from the greater curvature of stomach. On this axial image, we see this fungating type from the lesser curvature of stomach in the region of the body. This is in the region of the antrum. This is the infiltrating type. And this is the ulcerative type, where you see the ulcer here. You can see the defect in the growth, and this is the fourth one, is the infiltrating type. So not only can we identify the lesion, but at times CT findings can also contribute to making a histological diagnosis. An example of this would be like this, where we see diffuse wall thickening of the stomach with presence of calcification and low attenuation within the gastric wall. This would correspond to a mucinous carcinoma. Now, how do we stage the primary tumor? As I said, the extent is best staged on endoscopic ultrasound, where T0. Let me just, if we see that on this, T1 is still the muscularis mucosa till the submucosa. Till submucosa, it remains T1, and once it goes beyond the submucosa, beyond that hypoattenuating middle line, it gets into T2. And once it crosses the serosa and reaches beyond the serosa, it becomes T3, and extent into the adjacent organs becomes T4, where it involves the visceral peritoneum, or T4B, where it involves the adjacent structures. How does it look? How do these look on CT? So on CT, T0 would be no evidence of any alteration of the gastric wall. T1 would be seen as increased enhancement, which does not involve all the 3 layers of the stomach, which are identified on a well-distended stomach. Or there might be subtle obliteration of the middle hypoattenuating layer. Then T2 would mean that there is diffuse enhancement, that now you don't see all the 3 layers, you see them as a single layer. So this possibly indicates that the muscularis mucosa or the serosa has been breached or involved, and thus this goes into T2. We cannot differentiate between T2A, B, and subgroup on CT. and spread beyond serosa, which is identified by thickened gastric wall or blurred fat plane around the lesion, or irregular outer border of the stomach or the serosal surface of the stomach, would indicate tumor spreading beyond the stomach into the adjacent fat, which becomes T3. So obliteration of fat plane between the gastric tumor and adjacent organs is an indeterminate area where it could be T3 or T4. So for this CT remains at times inadequate, and definite T4 involvement is gross infiltration of adjacent organs. Now let's look at T1 is considered as early gastric cancer, and what are the various types of T1 which we can detect on CT. So type 1 is considered which is elevated and which protrudes more than 5 millimeter into the lumen. Any tumor from the mucosa which is projecting more than 5 millimeters is considered as T1. T2 is protrusion which is less than 5 millimeter. T2B would be essentially flat lesion or a plaque-like lesion which will be seen in an increased area of enhancement. And T2C would be a lesion which has a slight depression but which is not reaching up to the muscularis mucosa, which is penetrating into the muscularis mucosa but not extending into the third layer of the muscularis propria. So how would they look on CT? So this is a lesion, which is a polypoidal lesion, which is more than 5 millimeter thick, and this is a type 1 lesion. Here we see a smaller lesion, which is identified because it is enhancing. It is less than 5 millimeters, so this will fall in type 2A. And type 2B is a lesion which is a little more diffuse, plaque-like, but enhances profusely. But however, you can still see the hypodense area, so this is still 2B. We can see the hypodense area gone, but you can see the outer line. And type 3 is definitely this is an ulcerative type of lesion where we can see the growth in the antropyloric region and where we see an ulcer here, where there's a depression. So beyond type 1, anything which goes beyond the muscularis mucosa, which reaches up to the muscularis mucosa, is type 2 lesion or T2 lesion, sorry. So early T2 lesions can either be segmental, there can be a segmented involvement, or there can be a diffuse involvement, which gives a lobulated contour and often ulceration. You can even have lymph nodes in these, and you can identify these lymph nodes there. And here we see subtle blurring of fat planes, but this actually is not extending beyond the serosa. Another type of lesion which can we see on type 2 is diffuse wall thickening, which is there is the kind of the variety which forms the linitis, which creates linitis plastica, is the Skirus type of signet ring cancer adenocarcinoma of the stomach, which leads to diffuse wall thickening. And here we see that there is reduced sensitivity and diffuse wall thickening. So T3 lesions are lesions which have gone beyond the serosa, and you can definitely see that there is extensive blurring here on this image, as well as on this the area which is along the lesser curvature of the stomach. When we see this, there is also what we can also identify, that there is a vessel which is going here. This corresponds to the left gastric artery, which we need to identify as the short gastric artery. Left gastric artery would be here. And similarly, we can also see a lymph node here. This is a lymph node, and this is the infiltration in the perigastric area. So any invasion into the perigastric area beyond the serosa would constitute a T3 lesion. The T4 lesions extend into the ligament, into the various perigastric ligaments and into the adjacent organs. The involvement of the adjacent organs can be contiguous, direct contiguous involvement, or it could be through the various ligaments. So liver is invaded through the gastrohepatic ligament, whereas the splenorenal and hepatoduodenal ligaments are possible routes of spread to the pancreas from commonly through the hepatoduodenal ligament from cancer of the antropyloric region, whereas the splenorenal ligament from cancer along the greater curvature. Into the spleen, it goes through the gastrosplenic ligament and into the transverse colon via the gastrocolic ligament or to the greater omentum. The commonest involvement of contiguously is of the distal esophagus, which is involved in almost up to 60% of uh, cardiac of gastric cardiac tumors, and the other is duodenum from the antrum. However, one has to remember that these are not constituted as T4B lesions. Contiguously, they would be considered as T4 lesions, but not T4B. So these are these modes of spread through which ligament, as we had discussed earlier in the one of the earlier slides where we showed the anatomic and the vascular anatomy, that how you identify ligaments. So the gastrohepatic ligament or the lesser omentum contains the left and the right gastric vessels. So once you identify these vessels, you know you have identified gastrohepatic ligament or the lesser omentum. And through this, the common tumors to spread are those along the lesser curvature and the cardia, and the contiguous organ to be involved is the left hepatic lobe. The hepatoduodenal ligament contains the hepatic vessels, the hepatic artery, and the portal vein. And the tumors that spread from this are the tumors of the antrum and pylorus to the pancreatic head. The gastrocolic ligament contains the right and the left gastroepiploic vessels, which disseminate tumor of the greater curvature to the transverse colon. The greater omentum contains the epiploic branches of the gastroepiploic vessels, and the tumor from the gastric curvature of the body reaches the leads to omental caking or involvement of the stomach or the small bowel or even the transverse colon, the anterior part of the transverse colon. The gastrosplenic ligament contains the short gastric and the left gastroepiploic vessels near the splenic hilum, and from this, tumors of the greater curvature and fundus infiltrate into the spleen. The splenorenal ligament contains the distal splenic artery and the proximal splenic vein or the upstream splenic vein, and the tumors which spread from this are commonly along the greater curvature and the fundus of the upper body, and the organ which can be infiltrated is the pancreatic tail or the descending colon, which lies close to the splenorenal ligament or the splenic hilum. So knowing this is important because we can identify the various ligaments and detect early any disease spread which is occurring along these ligaments. This is not playing. Yeah. Okay. So there seems to be a lag on this. This I've already shown. Sorry, just let me go. Yeah. So these are examples of a T4 lesion. Here one can see the tumor from the greater curvature of the stomach along the posterior wall with contiguous infiltration into the pancreas. And also the next slide shows the colonic involvement from the tumor along the gastrocolic ligament. This we have already covered, and this I will not spend any time on this. So after we have staged the local extent adequately, though again I'd like to re-emphasize that this is better done on endoscopic ultrasound. However, CT does have a role to play in extent beyond the perigastric location through the various perigastric ligaments into the adjacent organs and identifying T4 disease. Next is to evaluate the lymph node and to stage the disease according to the nodal extent. So what do the malignant lymph nodes on CT look like? As a standard, we know most of the lymph nodes, we take it as a blanket sanction that any lymph node in minimum short axis diameter, which is more than 10 millimeters, is considered as significant. However, this is a little different for perigastric lymph nodes. The perigastric lymph nodes are considered involved or significant if the short axis diameter is more than 6 millimeter. So these perigastric lymph nodes are the lymph nodes which form this level 1 to 12 as per the uh, Japanese definition of upper abdominal lymph nodes, so which I will discuss in subsequent slides. Then beyond the perigastric or tier 2 lymph nodes, any lymph node is considered involved. These are the lymph nodes which are along various vessels, if they are more than 8 millimeter in short axis diameter. Other features which point towards involvement of lymph nodes is a rounded shape or a near round shape where the longitudinal to transverse diameter ratio is 1.5, is less than 1.5. So it tends to appear a rounded shape, means that it is infiltrated. And at times, if one sees this finding, so even a size less than 8 millimeter, one can predict that this is a possibly involved node. A node showing central necrosis or an obliterated fatty hilum, which is difficult to detect as it is on nodes which are less than 6 millimeters. But yes, if a small node also shows this sign and one can see this, one can make a definitive conclusion that this probably lymph node is also involved. Or a highly enhancing or a heterogeneous lymph node is also considered as a possible involvement. So sensitivity of CT for lymph nodes in various studies ranges from 60 to 90%, and it would depend on the various local factors, the image quality, the scan parameters, the adequate distension, the use of adequate contrast media, a lot of factors. And obviously, more fat allows us to see these lymph nodes better. So this is how we identify. This is how we identify or label the lymph nodes. So the perigastric lymph nodes we can see are along the proximal greater curvature, paracardial, so suprapyloric, infrapyloric. But then now it's more standardized to use a numerical identity, to give a numerical identity to these lymph nodes, because it leads to standardization. Like it has been started for various areas like the mediastinum, like the axilla for breast cancer, the cervical lymph nodes levels. Similarly, now we have a station concept for upper abdominal lymph nodes proposed by the Japanese Society of Oncology to standardize, and it is a good this thing to follow it, because most of our GI surgeons and oncosurgeons want this information. So what are the lymph nodes? Earlier days, it was the station of lymph node which used to decide on the node staging. However, from the 6th edition of AJCC, it has been revised to the number of lymph nodes involved, perigastric lymph nodes. So when there are 1 or 2 lymph nodes identified as possible involved lymph nodes for showing the features of involvement as on CT, it is N1. N2 disease would correspond to 3 to 6 regional lymph nodes being involved, whereas N3 is divided into substages A and B, where up to 15 regional lymph nodes, 7 to 15 is 3A, and involvement of more than 16 lymph nodes is N3B. This involvement, N3A and N3B, is now more of pathological classification once you have the post-operative specimen for the pathologist, because we possibly on CT cannot assess all the cannot possibly assess 16 lymph nodes, but definitely more than 7 to up to 15, we will be able to see that. So this is the Japanese Gastric Cancer Association, which has labeled these lymph nodes and given them a station number. This was done in 2011, and these are up to level 12, up to station 12, are considered as loco-regional. The stations 14 and 16 gain particular importance that 16 makes it metastatic as well as 14. They all make it disease metastatic, whereas 13 and 15 would still keep it at 4A or 4B. So why 16 is beyond surgery? 14 also people have taken up for surgery, but the recurrence rates are much higher, especially if these lymph nodes are to the left of the superior mesenteric artery. So even this we have to remember and give that if you're giving them a lymph node of 14, level 4, station 14, we need to tell our surgical colleagues whether this is on the left or is it to the right of the mesenteric artery, because this has a prognostication value. So the lymph node involvement is also depends upon the anatomical site of stomach CA. So the left gastric lymph nodes on the lesser curvature or along the greater curvature are the lymph nodes which can be involved from any location. The upper third of stomach tends to involve the paracardial or the celiac, along the celiac or the splenic, or the along the splenic artery as well as the paraaortic. Whereas the lower third involves the infrapyloric in the regional perigastric lymph nodes or along the hepatic artery or the superior mesenteric vein in the non-epigastric tier 2 lymph nodes. So this is what a lymph node would look like. This is the growth where we see here, and these are the lymph nodes. However, one needs to see that this is a rounded one, and this is definitely a lymph node. We can also identify a retrocrural lymph node here. They are enhancing significantly. So these and rounded on top of that. So this becomes definitely involved lymph node. In this image, we again see multiple lymph nodes which are involved. They tend to be rounded, enhancing more than the other lymph nodes, whereas this small lymph node, which is less than 6 millimeters possibly, is likely to be non-involved. So we need to differentiate them on CT and not take it that we see a lymph node and just include it in a count of 1, 2, 3, 4, 5, 6, 7. So we need to differentiate these lymph nodes. As in India, lymphadenopathy, as it is quite common because of TB being endemic. Next is to see the presence or absence of metastasis. The commonest organ to metastasize hematogenously is the liver, because the spread is through the portal vein as the stomach drains through the portal vein, and liver would filter the tumor cells the first. The other less commonest hematogenous sites include the lungs, the adrenals, kidneys, bones, and drain in that order. However, any organ can be involved from gastric CA, from metastasized from gastric CA. Lymph node involvement outside the perigastric location, tier 1 and tier 2, would constitute M1 disease, including involvement of the retropancreatic paraortic lymph nodes, the pancreaticoduodenal, the peripancreatic, posterior peripancreatic, the superior mesenteric, the colic, middle colic, the paraortic, as well as retroperitoneal lymph nodes. So even peritoneal metastasis is metastatic disease, and one can also see transperitoneal spread into other organs, into other viscera. The commonest one being the involvement of the ovaries, which is known as the Krukenberg's tumor. Yeah, so on this slide, or in these images, we see stomach greater curvature growth here, which is a polypoidal growth, which has gone beyond into beyond the serosa, and there is extensive peritoneal seeding. This forms peritoneal carcinomatosis of stage M4 and constitutes a metastatic disease. On this patient, one can see the involvement of the ovary, the heterogeneous mass involving the ovary, and this forms a Krukenberg tumor. Also, one can note the presence of ascites in this. So at times, you can have a second malignancy as well, which can be a primary ovarian cancer because ascites is more common. So one at times might need to do a biopsy of the tumor of this lesion as well to differentiate a Krukenberg tumor from a primary ovarian CM. So again, just reiterating an important point that direct extension into liver, colon, pancreas, diaphragm does not constitute M1 disease, but is a T4B disease, which is still operable. And remember that still the best survival is obtained from surgery. Also, at the same time, I would also like to point out that one does need to identify the involvement of the crura because it would change the approach to surgery. Whether it needs to be a purely abdominal approach or a thoracoabdominal approach. So just coming back to it, we reiterate the fact that adequate preoperative staging is essential in planning the treatment strategy and selecting whether the patient is feasible for surgery and what is the optimal surgery going to be. Also, accurate postoperative stage classification is useful for estimation of prognosis and making decisions on postoperative treatment modalities. As we have already discussed and shown that CT does show evidence of peritoneal seeding. However, it is not the end of it all, and the peritoneal seeding can be radiologically occult, as well as metastatic spread also can be radiologically occult. And there are certain situations where one can, by performing additional investigations, can upstage the disease, and this can in turn alter the treatment modality which will be offered to the patient. So where is diagnostic laparoscopy indicated? For clinical T3 stages or greater, or if there is a clinical suspicion or suspicious nodes without distant metastasis on imaging. So this is done to exclude radiologically occult involvement of the peritoneum. If a lesion is identified on laparoscopy, a biopsy is taken, and if there is nothing which is biopsyable, then washings are taken for cytology and cell block to look for presence or absence of malignant cells. PET-CT also has a role, especially for T3 disease or disease with late T2, advanced T2 or early T3 disease, where and even T4 disease, where radiologically occult metastasis may be missed. PET-CT also identifies lymph nodes beyond by showing increased uptake, and it is most commonly used in post-operative follow-ups to detect early recurrence or to see a response to chemotherapy or radiotherapy if being given to the patient. However, PET-CT has its limitations, especially in mucinous or serous type of cancers, because they show relatively less uptake and they might be missed. And also at times in certain types of lymph nodes where a lymph node may be negative on PET-CT but may show features of involvement on other modalities. So here is an example of a growth involving the proximal stomach. Is a serous type of a growth which is extending into the G junction. And here one can see on PET-CT there is uptake in the region of the growth. You can identify the growth corresponding to this. However, this lymph node does not show any increased uptake, but it shows a rounded appearance, is borderline 6 mm. And when you do a diffusion MRI, just as a problem solving, one can see that it shows increased uptake. However, if this is a decision changing, then you might like to subject this patient to endoscopic guided biopsy if not if percutaneous one is not feasible. MRI has, though it is equivalent in most conditions to CT, however, its availability, the cost, and the clinicians' reluctance to use this as an imaging modality because of not because of lack of familiarity, and that on CT they tend to see more readily only one sequence. It is either hyperdense, hyperdense. On T2, there's so many on MRI. There's so many sequences. So surgeons still like to prefer CT as a modality of choice for evaluating stomach CS or abdominal and chest malignancies. So MRI has been classically used for detecting liver metastasis, where you have a suspicious lesion which is appearing cystic, not showing enhancement on CT, and then you do an MR to look for any restriction of diffusion or multi-T sequences to see if it is a purely cystic lesion, which would show an increasing signal on increasing TE, whereas any other lesion would show a reduced signal with increased TE values on heavily weighted T2 images. So as it said, that diffusion weighted imaging helps in distinguishing early gastric tumor from normal gastric wall. However, that can easily be achieved by EUS and EUS guided biopsy. And also it can facilitate at times detection of peritoneal carcinomatosis, involvement of the peritoneum, and involvement of lymph nodes by reduced ADC values or showing restricted diffusion. Well, we have covered the primary. My major talk is covered. So, but no talk on gastric malignancies is complete without talking about the other gastric malignancies like the lymphoma, which constitutes 3 to 5%, the malignant GIST, carcinoid, and metastasis, which might involve the stomach. Other uncommon tumors are Kaposi sarcoma and miscellaneous tumors. Most of these miscellaneous tumors are all mesenchymal tumors and have now been actually combined or collated with GIST. So why is lymphoma important? Because for the intestinal GI tract, the stomach is the commonest site for lymphoma. The commonest variant is non-Hodgkin's lymphoma, but a special type of lymphoma, which is apparently has an association with H. pylori infection, is the MALT or the mucosa-associated lymphoid tissue lymphoma. In high-grade gastric lymphomas, the disease is usually greater at presentation with involvement of adjacent organs, perigastric lymph nodes, but one hallmark, even with such diffuse disease, the luminal compromise is generally absent, and that is a pointer for us that this growth can be a lymphoma. So lymphoma, the various types of lymphoma can mimic gastric primary adenocarcinomas. The classical CT features of lymphoma are wall thickening greater than 1 centimeter, more than 50% infiltration of the wall. That is, you're going beyond the mucosa, and circumferential involvement of most of the stomach, infiltration of the stomach wall, homogeneous wall thickening with preservation of the mucosal pattern of the gastric rugae, and presence of lymph nodes on either side of the mesenteric vessels, which is called as the sandwich sign, where the mesenteric vessels, the enhancing mesenteric vessels, are sandwiched between the lymph nodes on either side. So this is a point which I've already mentioned, that luminal compromise can be preserved late despite extensive growth, which is a classical sign for lymphoma. So these are two examples of lymphoma. The first one is showing extensive wall thickening. This is the infiltrative variety of lymphoma, and this is showing a large growth with an ulcer crater. So this is the ulcerative type of lymphoma. Here we can identify lymph nodes. You can identify these lymph nodes. So lymph node involvement in gastric lymphomas is early and extend and can be extensive. This is another variant. This is the polypoidal variant of lymphoma, which is showing a polypoidal growth with a filling defect. And this is a nodular variant of lymphoma showing multiple this is wall thickening diffuse, and this is the nodularity of the wall of the stomach. This is forms the nodular variant of gastric lymphoma. The next common tumor is gastrointestinal stroma tumor. These were earlier referred to as leiomyomas, rhabdomyomas, and spindle cell tumors. All these tumors now actually form the broad category of gastrointestinal stroma tumor. These tumors arise typically from the submucosa, from the submucous region, from the muscularis and from the muscularis propria. So 60 to 70% of all intestinal GISTs occur from stomach, and almost 90% involve the fundus and the body, and the rest are found in the antrum. In this, the exogastric growth is a common factor. Men are more commonly detected with this type than in women. Clinically, they may present as UGI bleed, easy satiety, and weight loss due to large mass, which is compromising the stomach capacity, and they may also present with abdominal mass, pain, or vomiting. Because of its extragastric nature, endoscopy is limited in diagnosing malignant GIST, and actually endoscopy, unless the lesion is creating a focal bulge on the lumen, on the mucosa, they might actually be entirely missed. And even if they're detected on an ultrasound, if the needle is not penetrated deep enough, the biopsy can be negative, or if the sample targets necrotic non-viable tissue, your result on an endoscopic biopsy may be negative. One needs to know that, unfortunately, I don't have this case, but the gastrointestinal tumors on presentation generally are very large unless detected incidentally. They tend to be predominantly exogastric. They are extremely heterogeneous with extensive areas of central necrosis and liquefaction. So much so that they can at times be cystic. Unfortunately, I have misplaced this case. This was one of our diagnostic dilemma which we had with a large mass which was arising from the stomach. Now we know retrospectively that it was arising from the stomach. It had infiltrated and through the liver and was having a subcapsular presentation and indenting the diaphragm through the liver. It was so cystic that so necrotic we could even identify floaters in this on ultrasound. And imaging on CT cross-section, it did not show any enhancement. So we were sure that we are probably dealing with a liver abscess, but patient did not have any of those classical features of abscess. Biopsy was done, it was negative, it did not show any infected focus. Non-viable, probably the non-viable tissues were targeted, it was negative. On surgery from the walls, it was confirmed later on that this was actually a GIST. I wish I could have shared this case with you. This was the thing which had make us think a lot, and it remained a diagnostic dilemma till surgery and pathological confirmation. So just benign versus malignant tumors, what are the features which favor a malignant GIST are classically an exogastric location. The benign ones tend to be more towards the lumen, indenting the lumen. The diameter greater than 5 centimeters is a favorable for malignant potential, and extension into adjacent organs favors possible malignancy. So this is a large submucosal tumor. On barium, it is seen indenting. There are specks of calcification, and there are areas of amorphous calcification, which shows that possibly it is a GIST exophytic tumor with calcification. More or less, it will turn out to be a GIST. This predominantly a necrotic component in the center with peripheral enhancing walls, not involving the mucosa being spared, is just arising from the lesser curvature of the stomach. This is another tumor arising from the greater curvature, extreme heterogeneity. This extreme heterogeneity with extensive necrotic areas is almost a classical feature, and that the mucosa is paired, then it helps us differentiating from gastric CA and from lymphomas. That lymphomas tend to be more homogeneous, enhanced better, homogeneously, more homogeneously. Necrotic areas are more common in GIST tend to be single. The lymph node involvement is commoner in lymphomas. So these are the points which will help us distinguish from lymphomas from GIST. So this is another smaller GIST you see arising from the antral region. Again, see, this is a small tumor with a large, with a significant exophytic component, where the exophytic component is more than 50% of the tumor. And look at the size of the tumor. It's small, but look at the heterogeneity. A gastric C this size, or probably a lymphoma this size, would not show this much of heterogeneity. This is a large infiltrative GIST which has gone to involve the spleen. This is another example of GIST, extensive necrosis, ulceration, and look at this. Only the wall is enhancing. Rest all it appears to be cystic. So this is another GIST. This we have already discussed. The differential needs to be from a lymphoma, from a metastatic melanoma, from that again, metastatic melanoma, if a submucosal will tend to be multiple and may not be single, whereas GIST tends to be single. So this is another example of a GIST. Again, high necrotic tumor, poorly enhancing, and on once you see a PET CT, there you see that hardly any tissue is active. The activity is at the periphery of the wall or on the walls, anterior as well as posterior walls. So if you were to sample this and you have not targeted this area, this might be missed. So this is of this is of valuable importance for the endoscopist that needs to take in a biopsy, including the wall, or if we are doing a percutaneous biopsy, to include the wall of the lesion at the time of taking a true-cut biopsy. The next ones are the neuroendocrine tumors or the carcinoid. These arise from the Kulchinski cells in the gastric mucosa, and they may secrete various types of vasoactive amines, but generally tend to be non-secretors and are not detected early, are mostly seen incidentally. Stomach is a relatively uncommon site for gastrointestinal carcinoids, and however, one need to know that they tend to metastasize early into nodes as well as distant metastasis, most commonly into liver, is fairly early. Neuroendocrine tumors can be of three types. The commonest one is type 1, so 70 to 80% of these, and these tend to be multiple, and these are associated with chronic atrophic gastritis. The lesions are polypoidal or nodular lesions, commonly seen in the fundus or body. These type 1 tumors tend to metastasize late, and they are less than 1 centimeter. Type 2 are associated with Zollinger-Ellison syndrome or men type 1, whereas the metastatizing one are type 3, 15 to 25%. These tend to be larger. They can be solitary or multiple as well. These are aggressive lesions. Perigastric infiltration is early, and at detection, almost 75% of these tumors would have metastatized either to lymph nodes or to the liver. I will not discuss the primary tumor. Here, the only thing to know about lymph node staging is there is only two. Either it is N0 or N1. So if it is not on the number, if there is regional lymph node metastasis, it is N1, clearly. And metastasis is also similar. If it is confined to liver, it is N1A. Anything more than one extrahepatic site beyond liver is N1B. And having both extrahepatic and the hepatic sites is N1C. We've already discussed the CT features. So these are the examples: polypoidal lesions, multiple. Here again, these are nodular lesions and these are polypoidal lesions in the same patient. So multiple lesions are seen. So this, and look at them, how well they enhance. much more than the mucosa. They almost light up like a light bulb if they're imaged correctly in the arterial trays. Another case, very recently one, a PET CT was incidentally reported as gastric cancer. That is how it was continued to be treated. Look at this tumor, uh, a large tumor here. One can see uptake on PET, very PET avid. Lower down, again, there is a small lymph node here, perigastric lymph node. So this we thought was reported as a gastric CA, but on histopath it turned out to be a carcinoid. Metastasis to stomach is uncommon. The commonest is through the hematogenous, where the tumors being melanoma, breast, thyroid, testicular, or lung. Lymphatic spread is also known, and this tends to be in tumors which tend to spread more through lymphatic channels. Transperitoneal seeding can also occur on the serosal surface. So this is the metastasis generally occurs into the submucosa, and ulceration is common. So this ulceration and this kind of lesion is seen as a filling defect with an ulceration seen as a central barium pooling, which leads to central barium pooling, oral contrast, which leads to an appearance of a target sign or a bullseye lesion. This is an example of a submucosal lesion. We can see the intact mucosa. So this, is a submucosal lesion in a known case of CA ovary, turned out to be a metastasis on histopathology from CA ovary. This is a case of cholangiocarcinoma. It's a large tumor here. Here as well, this was a tumor seeding from serosal tumor seeding from cholangiocarcinoma. A few last slide. This is a metastasis from breast. On barium, you can see diffuse narrowing from CA breast. This almost replicates a serous carcinoma, appearance of a serous carcinoma, in which there is diffuse narrowing, poor distensibility, and this turned out to be a metastasis from breast. Just a few slides. Kaposi sarcoma now is a rarely seen entity. It was seen in patients of advanced AIDS, now because of retroviral therapy, and we have got good control on AIDS. So patients don't progress to severe immune deficiency or immune compromise. Hence, Kaposi sarcomas are rarely seen. So historically, they could be detected on barium, and they were seen as multifocal or multiple submucosal defects ranging up to 3 centimeter in size. They would often ulcerate and produce multiple bullseye-like or target lesion-like appearance. So this is an example. We see multiple lesions, polypodal lesions with central ulceration giving multiple lesions, or multiple target eye or bullseye appearance. So in summary and conclusion, I can say that beyond endoscopy and EUS, which are important for early diagnosis of cancer, CT scan and imaging modalities still have an important role to play. Even if lesions are missed on endoscopy, or they're not detected or endoscopy has not been done, an adequate distension of stomach, changing posture can help us evaluate and address suspicious or inconclusive findings on CT, and one needs to be alert to them. Knowledge of nodal anatomy and its surgical relevance is equally important, and one needs to follow, as far as possible, a standardized format of labeling, a standardized nomenclature. And if we are dealing in oncology practice, then it will be good to follow the system proposed by the Japanese Gastric Cancer Society. The knowledge and identification of perigastric ligaments helps us in look for early tumor spread or dissemination along these paths. The radiological findings that affect clinical stage, treatment, and prognosis need to be paid special attention to include perigastric fat standing, the degree of lymph node involvement, the perigastric ligament involvement, direct invasion into adjacent organs, and presence or absence of metastasis, because it is these findings which change the stage, the treatment, and prognosis of the patient. Thank you. In conclusion, I would like to say, I would like to quote Albert Einstein saying that education is not the learning of facts, but training the mind to think and apply these facts in our practice. Thank you. I'm open for questions, Dr. Gaurav, and would be willing to take on any queries from our budding, brilliant radiologists.
Thank you, sir. Thank you very much. And it was a wonderful treat for all of us to see all your collection and cases and the teaching files. Till now, we have not received any question. Just we can wait for 1-2 minutes, and then otherwise we can conclude. Any specific thing you would like to emphasize and you would like to tell to our students regarding the stomach malignancies, or any image specification for abdominal scans, or anything specific you would like to pass on the message, please? Sir.
Yeah, we tend to take upper abdominal CT series very carelessly and leave it at time to our technicians to do it and report it subsequently. But as a resident, I would like to tell them, be there, see the scan, evaluate, and because once the patient is gone, there is a role for change in posture. At times you see dependent edema, you are not sure whether there is a growth there, mucosal thickening which is identified, which the adjacent organ involvement, infiltration, all that. So all that can be addressed in the same sitting if you are alert to it, and achieve adequate gastric distension and change in position, posture of the patient, and rescanning in the same sitting. We all know how inconvenient it is for the patient to call him again and do the scan. Patient at first becomes jittery. Is something wrong with me? We can avoid all those kind of situations. So one needs to be alert to this for adequate reporting, and obviously getting a standardized form of lymph node imaging. Most of us don't work in oncology settings, will not end up working in oncology settings, but it is a good thing to follow a standardized nomenclature like we've started doing in Vidasan, because everybody does not use the same nomenclature, and we use these nomenclature like perigastric or pyloric, peripyloric, celiac, mesenteric, loosely, very loosely. It does not convey to our surgical colleagues that where exactly is this.
True. We got 2 questions, sir. One is how the epicenter of lesion is decided.
So, for this cross-sectional imaging is the best modality, and one needs to have a multi-planar imaging. Just plain axial is not sufficient to decide. So the best thing is to open it on a volumetric, on a 3D imaging, have all the 3 scrolls together where you can see that. And epicenter is decided by the term epicenter, the center of the lesion. So now the current CT modalities allow you to mark, and the same marker would be displayed on all 3 formats, like axial, coronal, as well as sagittal. And once you have that mark in place, then you scroll the images to identify from which area you are trying to differentiate it from incisura, from cardia, from G junction. So you see epicenter is exactly the center of the lesion.
So, second question is, can you please revise the nodal stations? Quick revision.
So nodal stations, if you would like to know, okay, so the nodal stations are regional and non-regional. Non-regional would become metastatic. So regional nodal stations are which can be divided into 2 types: perigastric and tier 2. Perigastric are right along the curvature, along the borders of the stomach, and tier 2 are along the gastrocolic, along the various perigastric ligaments, along the various vessels which course in these ligaments. So these lymph nodes there would constitute as tier 2, so they would still fall in the purview of regional lymphadenopathy. Anything beyond that would go into a metastatic or non-regional lymph node. So I'll just show that slide, which is on. This is easily available on the any Google it and you will find this nodal stations. It's not a bad idea to, it's very difficult to remember all these nodal stations. There's so many nodal stations to remember. So it will not be a bad idea to take a printout of this and keep it there. And once you be ready as a ready recorder. So for this, yeah. So these are the locations. Up to 12 up to 12 are considered definitely into regional. Among these, any lesion which is not along the vessel is considered as as a tier 2 lymph node. Does not change the nodal staging. Uh, Beyond 12 are considered metastatic, as he said, behind the pancreas head, that is posterior to the pancreas head, would fall into a retropancreatic. So that would make it any retropancreatic, para-aortic, mesenteric, along the colic artery would make it as a non-regional lymph node and would make it as a metastatic disease.
Great. And sir, is there any role of radiotherapy in stomach malignancies?
The radiotherapy, CCRT is one, combined chemotherapy and radiotherapy is done, and it does address disease. It can either be to reduce the disease burden or to make it operative in case you don't have clear planes. You want to control. It does have a disease. It does have a role, radiotherapy, but obviously the treatment of choice is still wherever possible, surgery. Surgery, as far as up to T4B lesions, surgery can be done. Even direct contiguous involvement, the lesion can just be shaved off from that surface. So yes, radiotherapy has a role, but only in advanced disease.
Okay. Any example of a tumor perforation or tumor bleed specific thing?
Oh, yes. That's a question which is very close to my heart. I have had to embolize a few gastric CAs which were hypervascular, and one of them was a carcinoid, which was an infiltrating variety of a carcinoid, which is fairly uncommon. It was so hypervascular that it had ulcerated, and as a result, it had bled into the stomach. The bleeding was profuse, and there is a role to embolize these. So first step of whenever these tumor for any gastric bleed, the first step is for the endoscopist to go in, find the cause of bleed, identify the site, do a local sclerotherapy, banding, and these procedures. And only if they are unsuccessful, that we go ahead and take them up for embolization. But let me tell you, before embolization, we always like to have anatomical roadmap through CT angiography and see if we can identify any contrast extravasation or a pseudo aneurysm or an abrupt cutoff of a vessel on CT, which is a sign of a diseased vessel and points us to the possible site of extravasation, which makes it easier for us to localize and locate this vessel when we do a TSA and go and embolize it.
Okay, sir. Thank you, sir. I think no more questions now. We are done.